Thank you very much, Radiology Without Borders, for allowing me to do this presentation under your platform. My name's Muleya Moshious, as you have noted on the first slide, and as well as the link that was shared by the secretary. I am a radiographer by profession, and currently I'm stationed at Victoria Hospital right here in Zambia, in Lusaka. Apart from that, I am equally the vice president for the Geological Society of Zambia. So we are going to share some notes on the role of ultrasound in ovarian stimulation. With the link that was shared by the secretary, the title was folliculometry, what we need to look at in terms of ultrasound. However, I thought probably we need to broaden it a little bit so that we can equally see the changes that takes place when they are doing ovarian stimulation. So we are going to delve into this study. At the end of it, of course, as indicated, we're going to have questions and equally contributions. I am a radiographer, I'm not a sonographer. And, probably much of the information that I'm going to be sharing is based on experience and a bit of some reading, less of classwork. So we are going to have our introduction. We'll look at the menstrual cycle, which I think just the basics about it, because I believe we know these things. Then we'll go into discussing now the protocol that we get to use when we are doing scans in ovarian stimulation. We're going to look at the baseline ultrasound, post-stimulation ultrasound, and the pre plus post ovarian or ovulation, sorry, ultrasound. So this is basically what we're going to be covering tonight, and I hope that we get to finish on time so that we can do other things. So by the virtue of me introducing the study, we are looking at ovarian stimulation. And by definition, ovarian stimulation is a pharmacological treatment with the intention of inducing the development of ovarian follicles. So you are basically inducing the development of the follicles in the ovaries. And this itself comes up with some complications, which includes ovarian hyperstimulation. We call it OHSS. It can also bring about embolism, thrombotic diseases, multiple pregnancies, as well as polycystic ovaries. Because of this, it is actually important for us to get to monitor the development of these follicles. And based on history, ovarian growth was monitored by the use of urine as well as plasma luteinizing hormone concentration. And of course, after a bit of some researches, ultrasound found its way into this, and now it is more or less relatively superior in assessment of follicular development. However, they get to use it with other ways. Urine and plasma is equally being utilized in most of the centers. So ours is ultrasound, and that's what we're going to be looking at today. We need to understand the hormones that tend to control the follicle formation or development, and the organs that are equally responsible who have a look at them as well. So we have the hypothalamus. Never mind the spelling there, we'll be able to correct it. So we have the hypothalamus that secretes the GnRH that gets to trigger the anterior pituitary gland to release two important hormones responsible for the growth and the development of the follicles. We have the FSH, which is the follicular stimulating hormone, and the luteinizing hormone. These two hormones who act on the ovaries such that they get to produce or develop the follicles. And as the follicles get to grow, they get to start releasing two equally important hormones, which are progesterone and estrogen. And these are the ones that gets to work on the endometrium, the lining of the uterus, the internal walls, such that it gets to prepare itself for implantation. This is the menstrual cycle that we are actually looking at. I think most of you are familiar with this. These are basically the changes that takes place in two important regions in as far as in reproductive is concerned. We have the follicular development, we have equally the endometrial changes. Then the hormones that are responsible for these changes. So day 0 to day 4, this is the stage when the uterus is actually shedding blood, and the wall of the uterus is slightly thick and it's going to be shedding some blood. Definitely it's supposed to be thick. Then when you look at the follicular development on the follicle side, you'll find that there are small follicles, very small actually. Most of the times they may not actually be seen on ultrasound, especially if you're using transabdominal ultrasound, you may not be able to see them. 4th to 12th day, you see a little bit of a reduction in the endometrial cavity in terms of the thickness. And on the other side, on the ovaries, you see that the follicles are growing in size. They will be bigger in preparation for ovulation. Day 14, now we are looking at a typical 28-day cycle. So the day 14, which is the middle, you see that there's some ovulation that takes place. The egg is released. And at this point in time, the uterus is going to be growing in terms of its endometrial cavity. It's going to be thicker in preparation for the implantation of the fertilized egg. Then the rest of the stages in the follicular development, you see the degeneration of the follicle, now the luteum, corpus luteum degenerating, and you see these changes in the on ultrasound as you scan these mothers. So the hormones there are in the middle that gets to control these processes. So we'll be able to see and be able to analyze the ultrasound appearances of all these stages as we get along with our discussion. So question, why do we need to monitor the follicles? We need to monitor these follicles in order to find the optimal dose for the hormones that they are using to induce, to stimulate the ovaries. Equally, if at all the dose that is being used is not okay, they need to adjust it. So patients get to respond differently. So when you are actually scanning and you see the way the ovaries are responding to treatment, you will be able to advise the doctors through your report the dosage that they need to use for this patient as they get to stimulate the ovaries. Equally, we need to determine the best time for ovulation. As we indicated earlier that what we are looking at is a typical 28-day cycle. There are other women that may not actually have a similar cycle. Probably others could have more than 28, others could have less than 28. So the day number 14 may not be actually the actual day of ovulation. So you need ultrasound to help us determine the best time for ovulation induction, the time when the ovum is in the follicle and they are able to induce it or probably get it and be able to do some insemination there. Also to time intrauterine insemination. Now, this one is typical of the endometrial cavity. So they need to time endometrial intrauterine insemination at a time when the uterus is actually ready, dependent on the thickness that we get to find as we scan our mothers. So indicated area, there are two types currently used in most of the centers. There are, of course, others that I didn't record, but in most of the centers, Of course, we only have one center here in Zambia. They actually use these two methods to monitor. There's TVS ultrasound. This one is basically for morphological growth of the follicles. Then they have serum E2, which indicates the functionality of the follicles. So these are the two commonly used methods, and today we're going to be looking at just ultrasound, and this is transvaginal ultrasound. The protocol, in terms of the consideration as we get to scan our mothers, we need to utilize transvaginal ultrasound. I think we cannot emphasize this more. The transvaginal ultrasound is more variable when you're assessing gynecological conditions. Your probe is going to be closer to the region of interest. As a result, you are going to have better visualization. You're going to have a more clear image, and you'll be able to see the ovaries more clearly than you would have seen them on transabdominal. For your own information, if you have done your assessment, actually, when you find a cyst on ultrasound transabdominally, and you also use transvaginally, you measure the same cyst, you realize that the measurements that you're going to take are not going to be the same. You can try that. I've tried it, and I've seen that most of the times the measurements that we get to use transabdominally, usually they are less in terms of size. Let's say transabdominally, you find you maybe a cyst is measured in probably 2 by 2 centimeters. When you do it to measure it transvaginally, it will be slightly higher. So we want to have the assessment or the monitoring that is closer to accurate as possible as we get to monitor these mothers. So privacy is very paramount here. We need to ensure that our mothers are protected, and we ensure that the room is secure. We lock if possible, and we do not allow other people to get into the examination room as we are seeing them. Competence of the staff, very key here. We need to ensure that the staff that gets to see these mothers is as competent as possible. We don't want a situation where the mother is told that the ovary is measuring, the follicle is measuring this. At the end of it all, you realize that the measurements were actually gotten at a wrong angle, and they get to increase the dosage, which will eventually lead to other complications. Or probably they get to do an ovarian or follicular induction. Then at the end of it all, you realize that the follicle does not contain an oocyte. So we need somebody who's competent, and preferably a female. If you don't have a female, even a male can do, as long as your client is okay with that. This is not very important, but we can try to see to it that we get to have one person following a case. So if it is, let's say it's me following a case, when I do the baseline ultrasound, I should be the next person to do the serial scans. And as I get to do the serial scans on a daily basis, or probably after 2 days, whichever schedule that we get to set on our own, I should be the same person. The reason is simple. If I do the scan and I notice, let's say in the baseline ultrasound, I notice that there's a follicle, which I assumed that could have been a dominant follicle. So when I get to scan after 7 days, I will be able to reassess that follicle that I saw and do the measurement to say if what I saw earlier was the dominant follicle or not. And I'll be able to make a comparison of the changes that takes place between the scans as I get to follow this patient. However, if you are not able to do that, well and good, just have the standards that outline the procedure, and everyone that gets to scan these mothers, they will be able to follow the same procedure. The technique, much of this we know our patient will have to empty the bladder, and they will equally need to lie on their back with flexed legs. Of course, their foot or feet stepping on the bed. Then we need to scan the ovaries in both longitudinal and sagittal planes. Then when we get to locate the ovaries, we need to centralize them on our image, on our screen as we get to do the measurements. There are those that get to have ovaries which are more anteriorly, probably anterior to the uterus. You may need to apply a bit of some pressure on the abdomen, lower abdomen, to visualize the ovaries. You just need to find a way of visualizing them. Okay, so let's look at now the actual scanning. So I indicated earlier on that there are two, probably three types, or three, but I say types, not types really, but three ultrasound stages. I would call them stages. So we have the baseline ultrasound, which is done between day 3 and day 4 of the menstrual cycle. Then we have the next one, which will be somewhere around 7 to 8 day of the menstrual cycle. Then we have the 14th, where we checked the ovulation. So this is the baseline ultrasound, which we do at day 3 and day 4. What do we look at? We need to look at the uterus. Now, this is a thorough assessment, because this is before they actually do the induction. You need to do this, not the induction, sorry, the stimulation. You need to do this scan so that you can be able to advise what the current condition of the uterus, the current condition of the ovaries, the fallopian tube, and so on. Under the uterus, you need to check on the shape of the uterus. You need to measure the size of the uterus. Equally, you need to check the echogenicity. Here we need to look for masses. Are there any masses around the uterus? Or are there masses inside the uterus? How is the endometrium? Are there polyps? Is there fluid in the uterus? Now, it is been noted that endometrium, it has been found that fluid in the endometrial cavity has a poor prognosis in terms of the treatment when these patients are stimulated. So before that, they will need to ensure that they clear the fluid before they get to give these hormones to the mothers. Polyps, the same thing. Masses, dependent on where the mass is, they can equally compromise on the stimulation of the ovaries. The other thing that I didn't do much research about is the UTI. Probably there's somebody else that could have had a bit of some literature, read some literature on this. UTI equally has a poor prognosis on during ovarian stimulation. So maybe somebody can share more on this, or we can go and read through to see the relationship between ovarian stimulation and UTI. On the ovaries, we need to check for masses equally. We need to check for cysts. And on the cysts, so we are looking at follicles, which are actually cystic in nature. So as we get to analyze the cysts, we need to look at their echogenicity. How do they look like? What is their content? We need to look at, to measure them in 2 dimensions. We can as well add the 3rd dimension to be more accurate. So measure, check the echogenicity. Is it purely fluid? What is it showing some enhancement, posterior enhancement? Check for the shape. Check for the shape. You will be able to notice as we get through the study, you will realize that certain shapes of the follicles it could mean something else, and you just need to indicate in your report the shape of the follicle that you are actually looking at. You also need to look at the artery edges, check at the abnormal shapes, of course, of the ovaries, measure the volume of the same ovary, and you need to check at the ovarian stroma, the middle region of Most of the follicles are usually almost on the edges. So the middle part of it, you need to reassess it, apply some color and Doppler there. I'll be able to give you, at the end of the study, I'll give you the parameters that we should be interested in Doppler as we get to see these patients. So typical to ovaries, we can check for PCOS. This is polycystic ovarian syndrome. I think there was some months ago when we had a case in the group for PCOS, and there were discussions between PCOS and cystic ovaries. So to diagnose PCOS, we use the Rotterdam consensus or criteria. And this is the criteria that was agreed upon by the physicians then, that would lead to the conclusion that this patient do have PCOS. So you need to look at the size of the ovary. It should be increased more than 10 cc. Never mind, I'll add it on the units there. The ovary should be more than 10 cc in terms of the volume. Then the stroma, the middle part of it, this one, if you're able to see my cursor, the middle part of it, what is the echogenicity? Is it hyper-echogenic compared to the edges? Then indeed you need to conclude that this is PCOS. You also need to look at the follicles of similar sizes. Now, when you check around the ovary, you'll be able to see the follicles, and the sizes of these follicles should be almost similar, between 2 to 9 millimeters. A lot of them criteria indicated that the number of follicles that we should use to determine PCOS is 12 or greater than 12. Now that literature is being subjected to a bit of some criticism, and what seems to be applicable now is more than 20. 12 was too little, probably because of the quality of the machines that they were using then. Now we're able to see more, and with the use of transvaginal, we are going to be able to see more. So for now, we are going to be using 20 or more follicles in the ovary. Something to note there, if there are follicles more than 10 millimeters, we need to repeat the scan in the next cycle. This basically means that they may not need to stimulate the ovary. The reason is simple. That could mean that the follicle that we are looking at probably possesses an egg. Is an ovulated follicle. So it's possible it could possess an egg, and when you stimulate it further, you may have overstimulation leading to OHSS. So when we have such a scenario and we measure, we find that there's a follicle that is greater than this, the best we can do is just to advise that we repeat the scan and the procedure after a month or in the next cycle. The serial scans, we begin having the serial scans between day 6 to 8. It can differ dependent on the cycle of the patient, as well as other conditions that could be associated with your own protocols as a hospital. So what do you do now when you are doing your serial monitoring or serial scans? You need to measure the volume of the ovaries again. So you need to measure bilaterally. You measure the left, you equally measure the right. Count the number of atrial follicles. Very important. I know the follicles could be many, but we need to count them. We need the number. The gynecologist needs the number of the follicles that we are seeing on ultrasound. Regardless of the size, we need to number them. We need to apply pulse and color Dopplers. I will be able to give you the normal parameters at the end of the study for color, for pulse Doppler. And we measure that on the stroma in the middle of the follicle. the ovary, just the mid, the stroma part of it. That's where we get our Doppler parameters. At this point, we should be able to identify the dominant follicle. Remember, when you are beginning the scan, the baseline one, you are able to probably see the follicle that could be bigger than the others. And you would assume that that could be what? A dominant follicle. But at this point, you are now able to identify, determine that this is a dominant follicle. Remember, when a dominant follicle gets to grow bigger than the others, the hormones that it gets to release suppresses the growth of other follicles. As a result, it will grow bigger than the others. And typically, the dominant follicle has the following features. I mentioned earlier on, the shape matters. So this is where indeed you need to take keen interest to identify the type of the follicle in terms of size, shape that you are looking at, to determine whether it is a dominant or it's a false one, false dominant. There are also false dominant ones. So a dominant one, the one that we're actually interested in, where they're going to do an induction of an ovum, should typically be round, should have smooth borders, and hypoechoic, like the texture. I should also show some posterior enhancement there, and these are typical signs of a simple cystic. And when we see this, we should be able to determine that this could be a dominant follicle. Once the follicle reaches 16 centimeters, now you have seen your patient at day 6, then you have measured your dominant follicle. Once you measure it, you'll be able to ascertain the growth rate of that follicle with the growth rate that is indicated here, which is 1 to 3 millimeters per day. And you'll be able to know that by probably day 3 or day 7, 8, or 9, your follicle is going to be around 16 centimeters. So once your follicle reaches 16 centimeters, then you need to start monitoring these patients by ultrasound on a daily basis. This is very important so that you don't get to miss the time when they're supposed to do an induction. Because if you get to miss it, probably you forget and you get to maybe skip even day 14, you go to somewhere around 15. You'll realize at the time they would want to do an induction, the ovum would have already gone, ovulation would have taken place, and you will not have any ovum to get for the mother to, for the doctors to do artificial ART in short. So 16 weeks, 16 centimeters, we need to daily monitor these follicles. Chair, I hope I'm loud enough. You may be speaking to yourself, eh?
No, we can hear you. Please go ahead.
Okay, thank you. So let's look at the responses. This is response to treatment, of course. Responses that we get to have with these mothers when they're undergoing ovarian stimulation. There are 3 types of responses. There's a poor response, a good response, and overstimulation. So under poor response, the ovarian volume will be less than 3 cc. Now, when you do your measurements after this client has been stimulated, you get to discover that the ovarian volume is less than 3 cc. And this can equally be used as a tool in the baseline to determine whether the ovarian stimulation protocol is going to be successful. In most of the cases, when you do your baseline and you realize that the ovary is as small as with that volume or less, then the possibility of getting the oocyte at ovulation, they're actually very slim. Then you also need to look at the atrial follicles. These follicles should under poor response, they should be less than 3. If the prognosis is good, they should be more than 3. Then we also look at ovarian stroma resistive index. It must be greater than 0.6. Then the ovarian stroma peak systolic velocity should be less than 5 centimeters per second. That is poor. Under good responses, the ovarian volume must be greater than 3 cc. The number of atrial follicles must be greater than 3. Ovarian stroma resistive index must be 0.6. Less, of course, less than 0.6. Then the ovarian stroma peak systolic must be greater than 5 centimeters. And this has very good prognosis as we get to induce these our mothers. Now, overstimulation calls for us to stop the stimulation. Once we get to discover these signs, we need to advise the doctor that I think we are overstimulating this patient and we need to stop. So these are the criteria: more than 3 follicles, larger or greater than 16 millimeters. You have more than 3 follicles which are larger or greater than 16 millimeters. The danger of this is you are more likely to have triplets at this point, multiple pregnancies. It's more or less like you are stimulating more follicles, meaning there are more dominant follicles here. And they are more likely to actually do ovulation at the same time. Assuming that you're not doing an induction and you are just, you allow the couples to get to meet at that moment, the possibility of them having multiple pregnancies, is it multiple pregnancy? Yes, are very high. So once you see this, you need to advise your clinicians that they need to stop the stimulation. Of course, you advise through your report in terms of how you do your measurements. Then if at all you get to find 8 follicles with 12 millimeters or more, even at this point, you need to stop. It may lead to OHSS. So I've been mentioning OHSS. This is basically ovarian hyperstimulation syndrome. So ovarian hyperstimulating syndrome is an exaggerated ovarian response to hormonal therapy. So when you are stimulating them, they get to be overstimulated. The ovaries gets to be overstimulated. Clinically, you are going to see the following signs: the weight gain, like the patient will gain a lot of weight, increased abdominal circumference. We are going to, of course, clinically, they will be able to see their ascites, their pleural effusion signs, also reduction in the amount of urine that the patient gets to give out, which is oliguria. Then on ultrasound, we are going to see that the ovary measures more than 12 cc, like bilaterally, both the 2 ovaries are measuring more than 12 cc. Then now we have multiple cystic structures of different sizes within the ovary. And we call this a spoke-view appearance. Then ascites and pleural effusion, we can equally see these on ultrasound. Once we see these danger signs, we need to report and indicate that the ovary has been hyperstimulated, and these are the findings. The doctor will be able to stop the induction and gets to start treating now the OHSS. We are almost done. So sonal appearances of mature follicle. Now, assuming that you are evaluating your patient and you are somewhere around day 12, day 13, then they want to do an induction. What signs are we going to use on ultrasound to advise our doctors to say, this is the right time, this follicle is now mature, you can actually do an induction? Number one, you need to see vascularity over the circumference of the follicle. At least 3/4 of the circumference should show some vascularity there when you apply your color. Then PSV, peak systolic velocity of the stroma, must be 10 centimeters per second. Then we equally measure the size of the follicle. It must be somewhere around 18 to 20 centimeters. So it is at this point that your doctors are going to now trigger or start their HCG, which is the drug that they use in the induction of the follicles or the oocyte. And then I earlier on indicated that there are changes that usually takes place in the endometrial cavity. So the changes that we are looking at, they are on the ovaries. So equally in the uterus, there gets to be some changes. I think the changes are typical of a natural cycle. Like there could be a little bit of some differences in terms of the limits for endometrial thickness, but it shouldn't be more than 2 centimeters. It should not be more than 2 centimeters at whatever stage. Of course, this is more at secretory phase, so you should not have endometrial cavity that is more than 2 centimeters. However, if you reach secretory and you identify that you have a mature follicle, then your uterus, in terms of the endometrial cavity, is less than 1 centimeter, then you should advise the doctor that actually the problem could be coming from the uterus as well, because the uterus does not prepare itself for implantation as the ovary is preparing itself from the other end. Sorry. Okay, post-ovarian findings. Now, this is post-ovulation. Sorry. So post-ovulation findings. When you scan your patient and probably you saw that mature follicle, then probably the patient didn't come for an induction, and they say, okay, no, we want now to do an induction. Can you please confirm if that follicle is still there? Or you need to assess the ovaries again to see if ovulation took place or it never took place. How do you determine that ovulation took place? You see that the follicle that you were seeing earlier on had disappeared. And when you see this, just know that ovulation took place. Then what you assumed to be a follicle then gets to have some irregular margins. Now that stops being now follicle, is now a luteum, corpus luteum. So you'll be able to know that ovulation here has taken place, and there's nothing else that you can do. You need to wait for the next cycle. Then intrafollicular echoes, of course, what you assumed to be a follicle gets to have a bit of some echoes inside there. It's no longer a follicle. That gets to be a luteum or corpus luteum. There could be some POD collection as well. That's the cauda collection. Sometimes you may have even fluid in the endometrium cavity as well, and this fluid should not go beyond 2 days. It should be less than 2 days. The fluid should be able to come out. And when you do your color Dopplers there, you'll be able to see that there's increased perifollicular flows. Then you'll be able to know that you have ovulation has already taken place, and if you need to stimulate again, you need to wait for the next cycle. This is where I rest my case, and thank you very much once more. Over to you, Chair.
Thank you so much.